Hello friends, a lot of you would have appeared for the recent INI CET exams. I hope you've all done well. The results will be out very soon. So what we're going to do today is discuss the memory-based questions based on your feedbacks, based on your recalls that were asked from the cardiology. So there were 3 or 4 topics that were touched. What I have tried to do is try to compile all the important points related to that topic so that if at all you have a repeat question based on that topic in the NEET exams, this video will help you out. Okay, so let's move on to the questions. So question number 1. So the first question was trying to test your concept about management of tachyarrhythmias, right? So the question was, a young female, how would you best manage a patient with hypotension and narrow complex tachycardia? Okay, so 2 key factors. See, in the exams, regardless of which pattern is followed, they always ask 2 things. One is facts and the second is concepts, right? So this is a concept based question, right? Now, what are the options? 1, would you give injection amiodarone? 2, would you give an IV adenosine? 3, would you give synchronized DC cardioversion? 4, would you give injection ibutylide? And 5, would you give a fluid bolus and follow it with a bolus of a vasoconstrictor, which is a noradrenaline, and continue an infusion of noradrenaline? Okay, so let us try and discuss. So as you all know that tachyarrhythmias can be classified into 2 based on the duration of QRS, right? So I'll just roughly tell you, if the duration of QRS is less than 120, we classify it as narrow QRS tachyarrhythmias. If the duration of QRS is more than equal to 120, we classify it as broad complex tachyarrhythmias. I would urge all of you to go through our ECG lectures wherein we have discussed this in detail. The lectures are available free on the app, right? So let us see how to manage tachyarrhythmia. So when we come to the management of tachyarrhythmias, the first question or the first important decision making finding is the hemodynamic stability of the patient. Okay, so whenever a patient with tachyarrhythmia comes to you, or you encounter a patient with tachyarrhythmia, or you have a question regarding a patient who is presented to an emergency with tachyarrhythmia, first thing to note is whether the patient is hemodynamically stable. Right? Now, what do I mean by hemodynamically stability? So, say for example, the patient has come to you with ventricular tachycardia. So, what does a ventricular tachycardia do? It increases the rate at which ventricle contracts. Fine? Thereby, the effective cardiac output throughout the body decreases. So, whenever you have ventricular tachycardia, the ventricular tachycardia can cause, number 1, hypotension. Why? Because the cardiac output is decreased. 2, it can cause heart failure. 3, it can cause angina. 4, it can cause altered sensorium or syncope because of decreased blood supply to the brain. Now, most of us have this misconception that hemodynamic instability refers only to hypotension. So that's why just concentrate on this chart, right? So the word hemodynamic instability is used to describe 4 things: hypotension, angina, heart failure, altered sensorium. So if you have a tachyarrhythmia plus any of these, okay, either hypotension or angina or heart failure or altered sensorium, what do these signify? Hypotension. Why? Because the heart is unable to push out cardiac output throughout the systemic circulation. Why angina? Because the first branch of aorta is coronary arteries. So when the cardiac output decreases, the blood supply to the heart decreases through the coronary artery, and then you can get angina. Why heart failure? Because tachyarrhythmia can produce left ventricular dysfunction. And why altered sensorium? Because when there is a decrease in cardiac output to the cerebral circulation, you can have an altered sensorium and syncope. So the moment you have tachyarrhythmias, hemodynamic instability, which means 4 of these factors, then the management is immediate electric cardioversion. Fine? No confusion at all. So all tachyarrhythmias, regardless of their origin, whether they are supraventricular or ventricular, if they present to you in the emergency, or if you have a question regarding the management of such an tachyarrhythmia with hemodynamic instability, your answer should always be DC cardioversion. Now remember this image. This is an image of a defibrillator, and through this defibrillator, what do? We give a synchronized DC cardioversion. So that is synchronized to R wave, right? The other way of giving a synchronized DC cardioversion is by applying these patches, okay, which are defibrillator patches. So what is the position where you apply these pads, these paddles or pads is one, you can either apply it one on the right anterior, that is just below the clavicle on the right side of the sternum, two on the left lateral, that is just below the nipple or the breast. That's one position. The second position that you can use to give the shock is applied antero-posteriorly. So what's the idea behind these positions? The idea is to give electrical energy, a shock that captures the whole heart. So when you place two defibrillators in this position, it is covering the whole of the heart. Fine. So that when the heart receives that electrical energy, it is stunned, and all those focuses that are responsible for producing, say for example, ventricular tachycardia or any other ventricular tachyarrhythmia or any PSVT terminates, and we expect that the sinus node will take over and the patient will convert into normal sinus rhythm. Fine. So remember, tachyarrhythmias plus hemodynamic instability, treatment, electrical DC cardioversion. Now, if your patient has a hemodynamically stable tachyarrhythmia, so if a question is a patient presenting to you with a tachyarrhythmia that is hemodynamically stable, the blood pressure is okay, patient does not have angina, patient does not complain of features of pulmonary edema like dyspnea, patient does not have altered sensorium, then focus on whether the ECG is narrow complex, that is a QRS of less than 120 milliseconds, or whether the ECG has a broad complex QRS of more than equal to 120 milliseconds. Fine. So look at the question, focus on word tachyarrhythmia, look at the hemodynamic stability. If the word is hemodynamically unstable, this is your answer. If the word is hemodynamically stable, then look at whether the ECG is narrow complex or wide complex tachycardia. Now, how do we manage this? I will be discussing in subsequent slide. What I want to just make an exception is, this applies for all tachyarrhythmias except sinus tachycardia. Okay? Why? Because most commonly sinus tachycardia is a reaction to some underlying disease condition. So if a patient with hemodynamic instability has sinus tachycardia, you don't give an electric DC cardioversion. What do? You try and find the cause of hemodynamic stability and treat the underlying cause, right? So just remember, in this graph, the exception is sinus tachycardia. Fine. Now let us move to this arm, the hemodynamic stable arm of tachyarrhythmia, which has two components, the narrow complex and the wide complex tachycardia. So DC cardioversion for all tachyarrhythmias with hemodynamic instability except sinus tachycardia, that is the tachyarrhythmia arising from sinus node. Okay. Now, what I've done is I have compiled strips of common supraventricular tachyarrhythmias as well as ventricular tachyarrhythmias, so that you see the NEAT is about to appear, and this can act as a revision for all the 4-5 tachyarrhythmia ECGs that are commonly asked in the exams. Okay, so which are the common tachyarrhythmias ECGs asked in the exam? One is of course the PSVT, two is multifocal atrial tachycardia, 3 is atrial flutter, 4 is atrial fibrillation. So these are all supraventricle. Why? They arise from above the ventricle. Now finally we have one arising from the ventricle, which is ventricular tachycardia. What I'm going to do, I'll just tell you the main points of distinguishing between this ECG. Now the idea of putting them together is because so that you can compare. So what is the difference between, say for example, multifocal atrial tachycardia, atrial flutter, atrial fibrillation and PSVT? The first is the PSVT. If you measure the RR interval, it's a regular tachyarrhythmia. Narrow complex regular tachycardia, diagnosis would be PSVT. Okay. Now all these three causes are causes of, or are ECGs of irregular RR interval. Fine. Of which the most common cause is atrial fibrillation. So if you measure the RR interval, you will see it is varying, and you cannot make any obvious P wave in this ECG. So P wave is absent in atrial fibrillation. Fine. Whereas what is characteristics of atrial flutter is this flutter wave. Can you see this sawtooth-like appearance? Yeah, sawtooth-like appearance of the P wave. Fine. I'll just try and zoom this for you so that it is clear. So can you see that triangle? Yeah. So that's the flutter wave, right? Now come down. There's no P wave and the RR interval is irregular. So that's how you differentiate fibrillation from flutter. Now how do you differentiate these two conditions from multifocal atrial tachycardia? In multifocal atrial tachycardia, you have well-defined P waves but of 3 or more different morphologies. The term itself is self-explanatory. Multifocal, it arises from different focuses of atria. So there will be different morphology of P wave. Fine. So if you see, you have a small P wave, then you have a tall tented P waves, you have a taller P waves. So you have P waves of 3 or more different morphologies, right? So just this is PSVT, narrow complex tachycardia, regular. This is multifocal atrial tachycardia, 3 or more abnormal morphologies of P wave. This is atrial flutter, you have the classic sawtooth pattern of P wave, and this is atrial fibrillation where you have an irregular RR interval with no P waves. Now finally, you have something known as ventricular tachycardia. Please go to the ECG lectures. I've explained it very beautifully in that. Whenever you see VV on ECG, it is ventricular tachycardia. Even if you miss this in your clinical practice, never forget this rhythm. Okay, because this is potentially fatal. Fine. So now what I will do is I'll just give you the treatment of choice for all these tachyarrhythmias. So for paroxysmal supraventricular tachycardia, the drug of choice is intravenous adenosine, that is preferably to be given through a wide bore cannula applied in the left antecubital vein, and the moment you give the adenosine, you're supposed to immediately flush it with saline and raise the left hand above the head of the shoulder. So why do we do this? Is because adenosine has a short half-life, right? It lasts in the circulation for around 5-6 seconds. So we want the adenosine to reach the heart, reach the AV node before it is removed from the circulation, right? So that's the way of giving IV adenosine. You usually give a 6 to 12 milligram dose of IV adenosine. The maximum dose is around 18 milligrams. Other drugs that you can use to terminate a paroxysmal supraventricular tachyarrhythmia is, of course, verapamil. You can give around 5 to 10 milligrams of intravenous verapamil, or you can give a diltiazem, which is 0.25 milligrams per kg dose, right? So these are the 3 drugs of choice for managing paroxysmal supraventricular tachyarrhythmia that is hemodynamically stable, which means that does not produce hypotension, angina, heart failure or altered sensorium. Okay, now let's move on to the next arrhythmia, the multifocal atrial tachycardia. Now multifocal atrial tachycardia is usually secondary or is more commonly seen in patients with COPD. So the primary treatment is to treat the underlying cause. Secondly, multifocal atrial tachycardia also has common secondary causes in the form of hypokalemia and hypomagnesemia. So when you have a patient with multifocal atrial tachycardia, please keep the potassium above 4, the magnesium above 2, and if at all you have to use some drug, the drug of choice would be non-dihydropyridine calcium channel blockers. So you can use diltiazem, you can use verapamil. If the patient does not have a history of COPD, then you can use beta blockers to suppress the multifocal atrial tachycardia. Fine. Now let us move to the next 2 common arrhythmias that arise from the atria and are very commonly asked in the exam. Okay, what are they? The atrial flutter and atrial fibrillation, right? Now what is the management of atrial flutter and atrial fibrillation? Now even if there is a hemodynamically stable flutter, now remember when you compare to flutter and fibrillation, flutter has a very good response to DC electric cardioversion. That is why if you have an atrial flutter and it is of acute onset, meaning it has been in the last 48 hours, 2, if you can rule out the presence of a thrombus or a clot in the left atrial appendage either by a transesophageal echocardiography, then if it meets these 2 criteria, that is acute onset of last 48 hours and 2 does not have a left atrial thrombus, then you can give a 50 joules of DC cardioversion to convert the atrial flutter into sinus rhythm. Fine, because the management of flutter and fibrillation, acute flutter and fibrillation has 2 important components. One, of course, is the rhythm conversion. So you convert flutter and fibrillation into sinus rhythm, and 2, of course, is the rate control. Now, what do I mean by rate control? Now, you see, atrial flutter and atrial fibrillation both arise from the atria at a rate of 250 to 300. Now, what will happen if all of these atrial impulses go into the ventricle? A patient with flutter will have ventricular flutter. A patient with atrial fibrillation will have ventricular fibrillation, which can be fatal. So that natural protection against flutter fibrillation from atria causing flutter and fibrillation in ventricle is AV node, right? So if you can give drugs that act particularly on the AV node, it will prevent the ventricular rate from rising. And that is why in the management of atrial flutter and fibrillation, one is of course conversion to sinus rhythm, for which you can use two things. One is DC cardioversion, the other is the drugs, and second is drugs to control the rate. Okay, now apart from DC cardioversion, what are the drugs? So there are mainly three drugs: dofetilide, ibutilide, and amiodarone. So these are the first line drugs that you can use to convert to sinus rhythm. Out of this, of course, dofetilide is an oral drug and ibutilide is an injectable drug. Ibutilide and dofetilide are more efficacious than amiodarone. So if you have the drug of choice for conversion of sinus rhythm, if these are the options, if dofetilide is also an option, that's the first option, followed by ibutilide. If ibutilide and amiodarone are given as the option, then the ibutilide will be the answer. Now, the other drugs that have recently come up is flecainide and propafenone. Now, these have also been used for what is known as pill in the pocket, right? So, say for example, a patient has lone atrial fibrillation, right? Atrial fibrillation, young patient, no comorbidities, no hypertension, no diabetes, has small episodes of atrial fibrillations. For terminating those episodes, you can take flecainide and propafenone as a single pill, right? So flecainide comes around 200 or 300 milligrams tablet, and propafenone is around 400 or 600 milligrams. So these are also known as pill in the pocket therapy for atrial fibrillation. So that can also be a MCQ question. Pill in the pocket therapy for atrial flutter fibrillation is flecainide and propafenone. Okay, now moving on to the next arrhythmia, that is the ventricular tachyarrhythmia or the ventricular tachycardia. Okay, now when we come to the management of ventricular tachycardia, again hemodynamically unstable, DC cardioversion. Fine. If the patient has a hemodynamically stable ventricular tachycardia, meaning that the ventricular tachycardia is not causing hypotension, is not causing angina, is not causing heart failure, is not causing altered sensorium, then there are two things that you should look in the question. So hemodynamically stable ventricular tachycardia, the next thing you should see whether the question mentions about the structural heart disease of the patient. What do I mean by that? See, ventricular tachycardia is more common in patients who have a heart disease. So say for example, dilated cardiomyopathy, hypertrophic cardiomyopathy, ischemic cardiomyopathy, patients who have coronary artery disease causing ischemic cardiomyopathy, patients of heart failure. So if the patient has a structural heart disease or not. Why? Because if the patient has a structural heart disease and an LV dysfunction, then the drug of choice is amiodarone. Fine. If the patient has a normal LV function with no structural heart disease, then procainamide is more efficacious than amiodarone in terminating the hemodynamically stable ventricular tachycardia. Although the most commonly used drug is amiodarone, if procainamide is an option provided in the question to manage a normal LV with stable ventricular tachycardia, that should be marked as the right answer. Now, I've just mentioned injection magnesium sulfate because that is the treatment of choice if you have what is known as Torsades de Pointes. Please go through the ECG class where these things have also been discussed in detail. So coming back to our question, how would you manage a narrow complex tachycardia with hypotension in this patient? Of course, the answer would be synchronized DC cardioversion. Amiodarone is the drug of choice for what can you control? Yes, you can control ventricular tachycardias, you can control atrial fibrillation, you can control atrial flutter. Okay, that is it. Ibutilide, again, the drug of choice, more preferred than amiodarone for flutter fibrillation, right? Now IV fluid bolus and injection noradrenaline bolus followed by infusion. So why has this been mentioned? So although it might not be a question that you can get in the exam, I'll just tell you why. Because one of the methods for terminating a paroxysmal supraventricular tachycardia in a patient whose blood pressure was low is you acutely cause an acute rise of blood pressure. So when the systolic blood pressure suddenly rises to 170, 180, 190, it stimulates the receptors in the carotid, and that can have a reflex bradycardia. So it's a vague, not used, okay, but since it's been mentioned in the books, that has been put as an option. Now coming to the next question. So the next question was from the topic of ACS management. Now if you go through our crash course videos, you would realize that we have already segregated these topics. We've given you important topics from which questions have been asked, okay? So we'll go by that pattern. So the next question was from the management of acute coronary syndrome. Right? So what was the question? A 45-year-old male comes with the complaint of 1. Chest pain. Fine. His ECG shows ST segment depression with T wave inversion. Fine. His troponin is positive. His echo done shows a normal LV function with no regional wall motion abnormality. What is the management? Fine. So first thing, what is the diagnosis in this patient? So you have a patient who has chest pain, who has ECG changes, and who has a positive troponin. So then the diagnosis is NSTEMI, okay, non-ST elevation MI, because there is no ST elevation. So what would you do? Would you take the patient to cath lab and do an immediate PCI? Would you thrombolize this patient with an alteplase, which is a fibrinolytic agent? Would you give him a loading dose of aspirin, clopidogrel, and atorvastatin? Would you give him a low molecular weight heparin? Or would you ask the patient to run on a treadmill and do an exercise test? So this question has multiple correct answers. Okay, so let us discuss this topic. So what is this question tried to ask you? It is tried to ask you, how would you manage a patient with acute coronary syndrome? You will always have one question from these two topics. One, of course, from arrhythmia, two, of course, from ECG, and three, from the management of acute coronary syndrome, because it has become an epidemic, right? So before we go into the actual management of acute coronary syndrome, let us try to understand the spectrum of coronary artery disease. So what do I mean when I say spectrum of coronary artery disease? What I mean to say is, let us understand in what ways does coronary artery disease manifest. What is coronary artery disease? Coronary artery disease is a disease of the heart wherein there is atherosclerotic narrowing of the arteries that supply your heart. Which are the arteries that supply your heart? You have one on the right coronary artery, and you have two on the left anterior and the left circumflex. So whenever there is an atherosclerotic disease that causes luminal stenosis, that causes luminal obstruction, that causes blockages in these arteries, the blood supply to the heart decreases, and that manifests as coronary artery disease. Some people call it ischemic heart disease. Fine, right? So let us see what are the manifestations of ischemic heart disease first. So one, whenever you have atherosclerosis in your coronary arteries, what does it do? It can either cause a gradual lipid accumulation and progressive luminal stenosis, okay? So you have, this is your artery, this is your intima, and gradual luminal obstruction, what will that do? Will decrease the blood supply to the heart. So when you have a gradual lipid accumulation with a thick fibrotic cap, that leads to what is known as a stable plaque. Now, a patient who has a stable plaque in coronary artery manifests symptoms whenever there is supply-demand mismatch, which means whenever his heart wants more blood, and if the coronary arteries are not able to meet that demand, there will be a supply-demand mismatch, and that will cause a relative ischemia. And such patients present with what is known as stable ischemic heart disease, also known as angina pectoris, okay, also known as chronic stable angina, also known as, the newer term is chronic coronary syndrome, okay. So these are patients who will give you a history of repeated exertional chest discomfort, right. So this is stable component or stable manifestation of ischemic heart disease. Now the same atherosclerotic plaque can suddenly rupture and give rise to what is known as an acute coronary syndrome. Now, acute coronary syndrome manifests as either unstable angina, non-ST elevation myocardial infarction, or ST elevation myocardial infarction. Now, what is ST elevation myocardial infarction? When you have ST elevation in the ECG. So, this you can diagnose based on ECG. Right? Now, how do you differentiate unstable angina and NSTEMI? Is based on troponin, cardiac enzymes. So, if troponin is positive, it is NSTEMI. Now, how do you differentiate chronic stable angina and unstable angina? So, unstable angina patient differ from chronic stable angina because chronic stable angina patient will give you history of exertional chest discomfort which relieves on rest and give you a long history. What about unstable angina? These patients come to you usually with the history of new onset angina, with the history of crescendo angina, that is angina that is increasing in frequency, intensity and duration. These patients will come to you with angina at rest and also post myocardial infarction angina. Fine. So, this is a spectrum of coronary artery disease. You can be asked question from each of these manifestations, the chronic as well as the acute. Now, before we understand what are the therapies that we give in acute coronary syndrome, let us just briefly revise the pathophysiology of acute coronary syndrome. So, what happens? So, suppose this is the arterial wall, this is the intima, these yellow dots are, the lipids, this is the platelet, fine, this is the laminar blood flow. Now, what happens? The moment there is plaque erosion or plaque rupture, okay, now the plaques that erode or rupture to cause acute coronary syndrome are usually thin cap fibroatheromas. So, they have a thin fibrous covering with a very large necrotic lipid core. So, the moment it ruptures, what happens? You have platelets and you have fibrin that gets accumulated. Tissue factor is released into the lumen and that activates the clotting system. You have other markers that are released, that is the collagen, the ATP, the epinephrine, the serotonin, right? There is activation of the coagulation cascade, right, ultimately leading to the formation of fibrinogen which gets converted to fibrin and which binds all the platelets. So, which are the players involved in the acute coronary syndrome? What are they? One is of course this platelet, this guy is very important, right? Two is the clotting system, three is this plaque, right? So, if we were to manage a patient, we have to target these three things. Okay. Now, the difference is whenever this plaque rupture causes a complete occlusion of the lumen, it results into ST elevation myocardial infarction. Whenever the luminal occlusion is not complete, the result is ST elevation myocardial infarction. Fine. Now, let us see what are the therapies available for management of ACS. So, what are the players? You have coagulation system, platelet and fibrin, fine. And when does STEMI occur? When you have a complete luminal occlusion. So, you must understand, so whenever there is complete luminal occlusion, the first thing that you have to do is establish the patency of that artery. And therefore, fibrinolytic therapy is a must in all patients with STEMI because that occurs because of complete luminal obstruction. Right? So, you understood this, revise this, freeze this chart, get this in your head because this will help you understand the drugs that are used in management of acute coronary syndrome. So, what are they? One is antiplatelets. So, we will have to give antiplatelets to all patients who have acute coronary syndrome. Two is fibrinolytic. So, fibrinolytic will need to be given only to those patients who have a complete luminal occlusion, that is only to patients who have ST elevation MI. Third is statins. Why? Because statins stabilize the plaque. Okay. And four is anticoagulants. So, to prevent the coagulation system from being activated. Okay. So, what I have done is compiled a table of all the therapies that are used in the different spectrum of coronary artery disease. I'll just walk through it, okay. So, you have the stable ischemic heart disease, that is the chronic coronary syndrome versus the acute coronary syndrome, right. And what are the therapies that we have? We have antiplatelets, statins, beta blockers, anticoagulants, fibrinolysis, ACE inhibitors and anti-anginals. Right. So, in a patient with a stable ischemic heart disease, the therapy involves one antiplatelet, either icosapent or clopidogrel, plus a high dose of statin. So, either you give 40 milligrams or 80 milligrams of atorvastatin, 20 or 40 milligrams of rosuvastatin, plus you give beta blockers. Why? Because beta blockers have a negative inotropic and a chronotropic effect. So, they balance the demand supply mismatch and help in relieving the angina, then you give anti-anginals. Now, as we all know from the pathophysiology slide that the stable ischemic heart disease or a stable plaque has a thick fibrous cap, right? There's no rupture, so there's no need for anticoagulants. Simple, right? There's no rupture to cause clot and there's no luminal obstruction, so there's no need for fibrinolytics. Therefore, anticoagulants and fibrinolytics are not required in a patient with stable ischemic heart disease. Okay, now move to the acute coronary syndrome. Now in acute coronary syndrome, since there is a rupture of plaque, since there is formation of clot inside the coronary artery, you have to give 2 antiplatelets. So you give either ecosprin plus clopidogrel, or you give ecosprin plus ticagrelol, or you give ecosprin plus prasugrel. Okay, so these combination. Along with that, of course, a high dose of statin, just like stable ischemic heart disease, right? Then the most important thing is, number 1, you must offer fibrinolysis for STEMI. And anticoagulation will be for both, because in both these cases, there is subtotal as well as total occlusion of the luminal artery. Okay, so 2 antiplatelets, statins and anticoagulants for both of them, fibrinolytic only for STEMI. Right, now also included beta blockers and ACE inhibitors. ACE inhibitors are given if acute coronary syndrome results in a decrease in the LVEF to less than 40%. Fine. Now, so let us just run through the question. So ACS management. What would be the right answer? Now it's easy to guess. Since our diagnosis is acute coronary syndrome causing non-ST elevation myocardial infarction, we have to give these patients 2 antiplatelets, high dose statin and low molecular weight heparin. Primary PCI and thrombolysis are the treatment of choice for ST elevation MI. Okay, exercise stress testing is done for patients with stable ischemic heart disease. You don't put a patient with positive trop and ongoing chest pain to treadmill, right? Okay, so that summarizes the management of acute coronary syndrome. Now we are not actually sure which ECG was asked in the exam. So there is one thing that you should not miss or confuse. See, the indication for thrombolysis and primary PCI is ST elevation, but there is one MI that produces ST segment depression. Which is that MI? I'm sure you would have all guessed it, posterior wall MI. Why? Because the posterior wall of the left ventricle gets infarcted, the anterior leads that we place on our ECG, V1, V2, V3 will show an ST segment depression. So if in your exam you have this question, please be very careful that this has not been asked. Right? What is this? See. So you have ST segment depression in V1, right, V2 and V3. Yeah, can you make that out? You can, right. But the R wave is more than S wave. So when you have ST segment depression in the anterior leads with a R by S ratio of more than 1, you must doubt posterior wall MI, and if this was your ECG in the exam with ST segment depression and T wave inversion in the precordial leads, then the answer would have been fibrinolysis or primary PCI. So don't fall for the trap. Please remember the exception to all that is posterior wall MI. Why? Because posterior wall MI does not have ST elevation. And if you look at this ECG very carefully, then you can actually make out then there is ST elevation in lead 1 and AVL, which looks at the lateral side of the heart. So it is actually a posterolateral MI. Fine. So please be very careful, right? Don't just think that all ST elevation is only indication. This is a loophole that can be quizzed in the exam. Posterior wall MI. How do you diagnose? ST segment depression in V2, V3 and V1 with R by S of more than 1 in V2, V3. This patient had just come to us, I think, a few days back. Yeah, on the 23rd. Yeah, and he had this MI, but he was COVID positive, so we chose to thrombolyze him with a single dose of tenecteplase, and this is his ECG, 90 minutes post thrombolysis. So look at the remarkable improvement in the ST changes. Okay, so don't fall for this ST segment depression. This is the only indication of thrombolysis with ST segment depression, the posterior wall MI. If you want to confirm the diagnosis, take V7, V8, V9. Okay. So if this is your ECG, answer should be primary PCI and fibrinolysis. Now coming to the third question that was asked, so that was from the topic of hypertrophic cardiomyopathy. Now the questions were directly from the LMR notes of our hypertrophic cardiomyopathy. I'd request you all to download the LMR notes from our app. It's free. Almost 70 or 80% of the current INI CET questions were from the LMR notes. Please go through them. Okay. So what was the question? A 40-year-old football player felt lightheaded during a football match. On evaluation, his echo shows what is known as SAM. So systolic anterior motion of mitral valve leaflet. So what findings can you get on examining, one, the pulse of this patient, and two, in the murmur of this patient? Okay, so these were the options. So what is the pathophysiology that has been asked is hypertrophic cardiomyopathy. Why? Because systolic anterior motion of the mitral valve leaflet is characteristics of hypertrophic cardiomyopathy. So what I'll do is I'll give you all the high yield points of hypertrophic cardiomyopathy so that you can answer any question related to that in your coming NEET exam. So the answer to this question is of course pulsus bispherians. Why? Because pulsus bispherians is seen in hypertrophic cardiomyopathy. And the murmur that you get is a systolic ejection murmur. The murmur increases on standing and increases on Valsalva. So all murmurs, like all left-sided murmurs, decrease in intensity on standing and Valsalva, except the murmur of hypertrophic obstructive cardiomyopathy and mitral valve prolapse. So these are the only two murmurs that become louder and longer when you stand up, when the patient stands up and performs a Valsalva. Right? So standing up in Valsalva increases the intensity of only these two murmurs, HOCM and mitral valve prolapse. All other conditions of the left side, the murmur decreases. Okay. So let me just revise for you the basic various pulses. So this is a normal pulse. So you have one wave in the systole, other in the diastole. This is pulsus parvus et tardus. So that's a slow rising and a delayed peaking pulse. This is seen in aortic stenosis. Then there are three types of bifid pulse. One is of course the dicrotic notch. When you have two systolic peaks, this is seen in severe AR and AS plus AR. Okay, and then the other cause of bifid pulse is a hypertrophic obstructive cardiomyopathy. Now what's the difference between these two images? Both are systolic peaks, but here the second peak is of dome pattern, so it's of spike and dome pattern, whereas in AR both the peaks are almost of the same amplitude. Fine. The third cause of bifid pulse is when a patient has an intra-aortic balloon pump placed inside his aorta through the femoral artery whenever for the management of hypotension or cardiogenic shock. So in such a case, again you will have a bifid pulse, but one in systole, one in diastole. Now what is pulsus alternans? When you have alternating amplitude of the pulse, and it is seen in when? It is seen in conditions of acute left ventricular failure, severe heart failure, hypotension and shock. Okay, so I'll just give you the high yield points of hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is a condition that is characterized by thickening of the left ventricular myocardium, right? So what happens is the interventricular septum, the lateral wall, everything thickens. The left ventricular cavity narrows, right? And every time the left LV contracts, right, the anterior mitral valve leaflet comes and obstructs the left ventricular outflow tract, right? So you can have two types of hypertrophic cardiomyopathy. 70% of the cases are obstructive cardiomyopathy and 30% can have non-obstructive, wherein there is only hypertrophy of the LV myocardium without any obstruction to the left ventricular outflow tract. Okay, it is also known as it also has apical variant, wherein only the apex of the left ventricle is hypertrophy and is known as Yamaguchi syndrome. So can be asked as a question. Now this term, asymmetric septal hypertrophy, wherein the interventricular septum is more thicker than the posterior wall or the free wall, giving rise to what is known as a banana shaped cavity. See, each of the words placed on this slide have been asked as a question in your MCQ exams. Okay, so systolic anterior motion of the mitral valve leaflet. Now what happens is, when you have systole of the left ventricle, normally the mitral valve is closed so that the blood does not leak from the LV to LA, the left ventricle to left atrium. But in hypertrophic cardiomyopathy, when the hypertrophied left ventricle contracts, it pulls the papillary muscle in such a way that the anterior mitral valve leaflet comes towards the left ventricular outflow tract and there is a mitral regurgitation. Okay, so SAM is associated with HCM. Just remember that. What are the characteristic features on microscopy? myocyte disarray and interstitial fibrosis. What is the characteristic ECG finding? Diffuse T wave inversion in the precordial leads and Q wave in the inferolateral leads. So you may feel that it is an old inferior infarct. So you get that pattern in HCM. Now, hypertrophic cardiomyopathy is the leading cause of sudden cardiac death in young. So what was that patient having, the lightheadedness patient? It was an episode of tachyarrhythmia and most likely a ventricular tachycardia. So that patient would ultimately also require a AICD implantation for primary prevention of sudden cardiac death. So when you have a patient of hypertrophic cardiomyopathy with unexplained syncope, with documented VT, right, or a family history of sudden cardiac death, these are indication for implantation of a automated implantable cardioverter defibrillator. It's a pacemaker-like device wherein you put two leads, one in right ventricle, other in the right atrium, and the right ventricular lead gives a intracardiac shock if the patient has a VT. Okay. Now, what are the clinical features, important clinical features? So you can have a raised A wave in JVP. You can have a double or a triple apical impulse. You can have LVS3, LVS4. You have a systolic late peaking murmur that becomes loud with standing in Valsalva. You get a spike and dome pattern on a aortic pressure tracing, which you have just seen previous slide. We have a hypercontractile LV. You can diagnose this condition by echocardiography and cardiac MRI. And the most common genetic mutations responsible for hypertrophic cardiomyopathy are mutations in the beta myosin heavy chain, the myosin binding protein C3, and the myosin light chain. So these are the three most common genetic mutations responsible for hypertrophic cardiomyopathy. So hypertrophic cardiomyopathy, the other questions that can be asked is how do you differentiate from athlete's heart? So see, athletes, those who train for running, those who are football players or cricket players who are intensive athletes, they can also have a hypertrophy of their left ventricle. But the difference is the athletes will have a symmetric LVH. If you remember, the other word for hypertrophic cardiomyopathy is asymmetric septal hypertrophy, right? So athletes have a symmetric LV hypertrophy. They have a dilated LV cavity. What happens in hypertrophic cardiomyopathy? The LV cavity narrows. Okay. Now the athletes have a normal diastolic function, and whenever the athletes leave their training, the hypertrophy resolves. So these are the contrasting features with HCM. Okay. How do you manage these patients? So you give beta blockers, you give rate reducing calcium channel blockers, you can use disopyramide, you can do alcohol septal ablation. So you inject alcohol through the septal branch of left anterior descending artery. That causes necrosis of the interventricular septum and hence decreases the thickness of interventricular septum and gives relief to the left ventricular outflow tract obstruction. Similarly, you can also do a surgical myomectomy. Fine. And most importantly, remember, AICD can be asked as a question for patients who have for the prevention of sudden cardiac death, if they have an unexplained syncope, if they have family history of sudden cardiac death, and if you have proven ventricular tachycardia, right? Now, to end this cardiology question session, I'd like to tell you that all the questions of cardiology were from our LMR notes. Please download those notes. They are free on our app. I would love to hear your feedbacks. Tell us topics that you found difficult to solve. Tell us topics that you find difficult to understand, and we'll try and help you. All the best.